Great. Well, good afternoon, everybody, and welcome to this meeting of the Mid and South Essex Integrated Care Board. Warm welcome to those members of the public who joined us here in Tilbury, and also to those joining online. The usual polite reminder that this is a public meeting, a meeting held in public, but it's not a public meeting. But very welcome to the members of the public who've joined us. Could I ask people to introduce themselves, first of all, around the table? I'm Mike Thorne, Chair of the Mid and South Essex Integrated Care Board.
Good afternoon, everyone. Tom Abel, Chief Executive of the ICB.
Matt Sweetin, Medical Director of the ICB.
I'm Ashley King, Director of Finance and Estates, deputising for Jen Kearton.
Hello, I'm Paul Scott, Chief Executive EPA and Mental Health Member of the Board.
Good afternoon, Joe Fielder, Non-Executive Member of the Board.
Good afternoon, Jeffrey Olsen, Associate Non-Executive Member on the ICB Board.
Good afternoon, Lucy Whiteman, Chief Exec of Provide Health and the Group Chief Nurse and a Provider Member of the Board.
Claire Hankey, Director of Communications and Partnership for the ICB.
Sarah Muckle, Director for Wellbeing, Public Health and Communities for Essex County Council.
Dawn Scrapefield, Acting Chief Executive for Mid and South Essex Foundation Trust.
Good afternoon, Neha Brown, Non-Executive Member of the ICB.
Good afternoon, Anna Davey, Primary Care Partner Member.
Good afternoon, George Wood, Non-Executive Member of the Board.
Hi, Emily Half, Executive Director of Strategy for the ICB.
Good afternoon, Giles Thorpe, Executive Director of Nursing for the ICB.
Thank you. I must obey the rules because otherwise people can't hear if they're online. Thank you very much. We've got the register of interests. I've not been notified of any change to that register of interests. Thank you very much. We've had one question from a member of the public. This question is from Peter Blackman. It's quite long, so I'm going to summarise it. The full question will be in the minutes of the meeting, but basically it's twofold. First of all, Mr. Blackman is kindly highlighting the hard work which has gone on from staff within Essex, and especially so in the current context where there is so much change going on in the NHS, and we know that we have got to downsize the ICB community quite considerably, and staff are managing to keep the things going on a day-to-day basis whilst that's happening. So thank you for that. And then secondly, Mr. Blackman seeks clarity as to why the recent findings of the CQC report regarding our hospital, the Mid and South Essex Foundation Trust, were not highlighted, and what steps are being taken to ensure accountability and improvement and the mechanisms for that, and whether we had done our best as an integrated care board to undertake that. And I think, Tom, you're going to reply to that.
I am. Thank you, Mike, and thanks, Peter, for your question. So the CQC's recent well-led report for Mid and South Essex Foundation Trust, and the outcome of that is referred to within my Chief Executive report in section 2.3, and also it's referenced within Giles's quality report as well. Clearly, the findings of the CQC report are concerning and are being addressed through the established governance and oversight mechanisms we have in place between the ICB and the Trust. The statutory responsibility for the Trust leadership and quality does lie with its own board, and I know it is something that Dawn is working with colleagues across MSEFT in terms of the resolution of that, and our role as an ICB is to provide both system level assurance and escalation rather than direct performance management. The issues identified by the CQC are now subject to an urgent improvement plan, which is being overseen by the Trust and NHS England's East of England regional team. And alongside that, we at the ICB are actively monitoring delivery and understanding what it is that we can do to support the Trust in their improvement. Non-executive directors of the ICB and trust governors are engaged in that process, and the focus is and will remain on doing everything we can to strengthen leadership and governance at the trust, and we will continue to report and monitor this matter through the ICB's Quality Committee, our System Oversight and Assurance Group, and equally onwards to this board to ensure ongoing transparency and accountability on the improvement actions that are required. Thank you, Mike.
Thank you. We now move on to the approval of the minutes of the previous Part 1 meetings. There are two sets, the 18th of September, and we had an extraordinary meeting which was focused on the preparation for the new ICB set up within the East of England region. Are you happy that they are correct record? And you all know that silence is 1,000% agreement. Good. Matters arising not on the agenda, I've not been notified of any. I think there are a number of issues which continue in the papers that are coming before us. Anyone got any other matters arising? No? Yeah, of course, Joe. George.
I guess today, I think it was obvious that the amount of work that the organisation's expected to deliver, particularly up the run up to March, and at the same time, the work is going to go that way, and the staffing levels are crossing down. It's also flu season. It's also whatever. Having been through two reorganisations before myself, this one really worries me in terms of the amount of work coming for our people. And there's one thing saying, well, it's their job to do it. That's easy enough when you're not losing your job. So I think we just need to give due consideration as to how much extra work we're putting on, and if there's anything we can take away, because it all seems to be incremental from what I can see.
Well, Tom, anything you want to say? I mean, I think absolutely nobody is taking the efforts of anybody, and I know you're not thinking that we are, but nobody's taking any of this for granted. It is marvellous that people are managing to do what they do. But your substantive point is absolutely, is there something we can take away? And that's Tom.
So I think it's a conversation we are routinely having across the executive team. One of the things that I am trying to work with NHS England on is a lot of the incremental asks are particularly in relation to planning for next financial year and beyond. And there are certain components of that planning that perhaps they're not vital in terms of they have to be done by the end of March, and it may be better, particularly thinking about some of those areas where it would be good to get much deeper partner and stakeholder engagement to actually take a little bit longer over them. So I think our priority is we need to make sure we have got a good core plan in terms of a financial plan and a kind of operational plan for the next financial year. That's got to be our core priority, as well as what are the key system changes that we want to try and drive on next year. So there might be something for us alongside the joint committee just to make sure that we're on track with that piece of work, whilst recognising that some other pieces of work might take us a little bit longer to get over the line, and that will flow into 26, 27.
Yeah, thank you. It's a good point there, George. Any other matters arising? If not, we've got the action log and there are no outstanding actions there. So that brings us on to the Chief Executive's report. Tom.
Thank you, Mike. My report covers a number of matters. I just wanted to firstly, for colleagues who weren't at the Essex Joint Committee earlier, just to give a quick update on transition first of all. So we've now completed the appointment process to the proposed Essex Integrated Care Board's executive team, who I've listed, and we've also completed recruitment into the Executive Director of Neighbourhood Health role, and Beverly Flowers will be joining us from early December to take up that role. Secondly, we launched our consultation around the formation of the teams to support the proposed ICB yesterday. That consultation will run through to early January, with the anticipated completion of that in terms of people knowing the outcomes from that process by the end of March. And so it is going to be a time of significant work and obviously significant uncertainty for colleagues. At headline levels, we're looking at a reduction of around about 25% in terms of our pay bill for Essex moving forwards. So I just wanted to place on record kind of my appreciation for the engagement and professionalism of ICB colleagues, to date, but equally as we move forwards. Within the report, I also set out some of the guidance that has come out over the course of the last month or two. So we've seen the medium-term planning framework has been produced alongside the strategic commissioning framework. And so these are all things that we have absorbed and indeed are trying to reflect some of this within the proposed structure for the new ICB as we move through the consultation process. And equally, I just also wanted to draw attention to the work that's been going on around the Holly's GP surgery, where following CQC intervention, we unfortunately we saw an interruption to service provision at that practice. The team have worked really hard in order to try and restore services. We're not fully back up and running at this moment in time, but we are very nearly in that place. So a big thank you to everyone involved in that. And then in kind of more positive news, just in terms of some of the other developments, and so particularly I was delighted to go to the opening of the new Bewley Healthcare Centre, which has been a long time coming. We've seen the opening of the new Thurrock Community Diagnostic Centre, and again, I was delighted to be there. And we've also seen the opening of a new dental location in Grays. So we've seen some really good kind of practical, physical manifestations of expansion of capacity of service for people within Mid and South Essex. And so, again, a big thank you to all colleagues who are involved in that. I'll pause there, Mike, for any questions.
Thank you. It was nice to have developments which are sort of virtually from the head bone, the knee bone, and the toe bone. So good to see. I mean, that there's evidence that stuff is still going on as we work out how to reduce workforce by 25%, which would mean, around this table, 4 people would not be here if we were employees at the end of March, to give you an idea of the scale of change that involves in physicality. So thank you, Tom, and thank you for your hard work and leadership, which we appreciate as a board very much indeed. And we've all been, as it were, listening into the calls and the briefings about this, and they are open, honest, straightforward with colleagues, and that has to help people deal with this difficult period. And again, thank you for that. So any other questions or comments on Tom's report? Yeah, Joe.
Thank you, Chair. Tom, thanks for a really good and helpful, succinct report. And particularly like the fact you included all the positives, because I think we sometimes don't do enough of that. Just had one quick query, which is about the ICBs and the guidance. Some of the key implications, number 2 talks about local autonomy and accountability. I kind of get the bit about productivity, but I wondered if you could just share with us a little bit more of your thoughts around how accountability might change, and also the comment there on financial balance. Just maybe elaborate on those a little bit for us, because it's possible you're privy to more than we all are in the emerging guidance. Thank you.
Maybe a little more, but not a lot more, I would probably say. So we know that there's going to, so with the changing responsibility, so we will see the loss of, say, system control totals, and so each individual constituent organisation, be that ICB or be that a foundation trust or a trust, will be expected to have a financial plan that ultimately will get them to break even. I think there's recognition that there will be some places that won't be able to achieve that in the short term, and therefore we'll have to have an improvement plan over a period of time, which will be pre-agreed with NHS England. But there won't be the expectation, as there is at this moment in time, that the respective positions of each organisation within a system will be totted up, and an expectation to balance in that way. And so that will work quite differently. One of the things that I know that there's been a lot of work going on, and we expect to see through the new payment regime, is around how we can start to move towards payment mechanisms that incentivize productivity. So we know that there's going to be, for acute services for next year, the publication of a number of best practice tariffs. The intention around that is to try and encourage productive practice and more productive delivery of service. And equally, there will be, we won't be there in terms of the implementation of this next year, but there is a lot of work going on in terms of for community mental health services as well. How could that be reflected? And so I think what will be expected of ICBs in the future is how do we, through the contractual mechanisms we have in place and the commissioning arrangements we have in place, are commissioning services so they can be as productive and successful as we want them to be. And that's going to be a two-way dialogue between us and our providers in terms of how do we successfully deliver on that. The other thing that I think we will see is a changing of the oversight framework. And so we've obviously got the oversight framework at the moment for trusts. I think we'll see next year a publication in terms of how it will work for ICBs, with a much more focus on neighbourhood health development and the delivery of some of the kind of key 10-year plan commitments as well. So I think we'll see that come in due course. I hope that's helpful, Joe, but I think there's still a lot to come as we work all of this through.
Context is very helpful. Thanks, Tom.
Jeffrey, and then Paul.
Thank you, Tom. Again, I agree. Painting quite a busy picture, which is really positive as well. I think, and also I welcome the appointment of the executive neighborhood, because that took some time. So that completes that tier of leadership, I think, which is really good. I think my question is around this kind of multi-year planning, shift to multi-year planning. If you could just give one or two examples, what difference that means. So I can think of, for example, does it apply to Better Care Fund, for example? Will you be able to see that? Or Health Inequalities Fund, things like that. Just a couple of examples. Thank you.
Yes, so the idea of having a multi-year plan and multi-year allocations, which have just come in and we're just working through those at this moment in time, is intended, and so we can provide kind of longer term commitment to key activities, and particularly key transformation activities, to help drive change in those places where we feel it is most needed and warranted. And particularly, I think this will help address some of the concerns that we have in some parts of the community and third sector, where we have in recent years been unable to commit to anything longer than a year in terms of our relationship with them, which obviously really inhibits their ability to innovate and to do interesting things, which would improve outcomes and improve the effectiveness of NHS care and NHS services. So it will give us more options, I think, by being able to commit over a long time and plan over a slightly longer term horizon, rather than just kind of lurching 1 year to the next.
Thank you. Paul?
Yeah, thanks. So Tom, just going back to the comment Joe made about the removal of the system control totals, and for different reasons, virtually all of the organisations in Essex are under some sort of pressure, and it could signal, couldn't it, that we need to go back in our bunkers and just sort our own pieces out. But I know it's EPIR's intention. I'm pretty sure it's your intention that that's not the case. We do stay focused on integration and working together to solve health and care challenges of the Essex population. I just wanted to check that, I think.
Yeah, I think so. So I think we'll need to work together. I think that the question that we're going to need to answer through this planning round, Paul, is what is it that is within the gift of each organisation to solve in terms of the challenges they face, and then what is going to require system-wide work to address, and we're going to have to do that together across all parts of Essex. So yeah, that's very much the commitment. Again, the one thing that I don't quite know how it'll play out is clearly the accountability for that financial performance will run up still to NHS England, and so there's a how do we all individually protect against that as that becomes more real, and as the regulatory architecture stands up and starts to work.
So what happens then with cash that we've been given where we have discretion, and and to date we might have used that to support other parts of the system, are we now going to be positively prevented from using that in that way? Do we not know? Or, where are we going to be on that? Because otherwise you could close one eye and still see where we are now, couldn't you? If you see what I mean?
Yeah, and there's going to be a transition, isn't there, in terms of we're not going to lurch from exactly where we are today to where we are tomorrow. The key thing we need now we've recently had the allocations came on Tuesday, I think, right, actually. So the allocations came out on Tuesday. We're currently working that through. There's a number of big changes in terms of the way the allocations are constructed, and so deficit support funding has been cycled back into all of the positions and the allocations. We know that they're making certain changes in terms of to reflect waiting time differentials and things like that. So I think we need to work all that through. We need to compare that to the commitments that we've got across all commission providers across all of Essex. And so there's quite a lot of due diligence activities through transition around understanding exactly what's commissioned where, and what the and what that commitment looks like on an ongoing basis. And so we can then understand what our final position is. Now, as I said at the joint committee, we know that we're going to need to balance our investment and prioritisation around the core national priorities around access versus addressing some of the issues around health inequalities and some of those other issues that we know will underpin the future sustainability of the service. And that's where we're going to have to probably have some quite difficult prioritisation conversations about how we work in the future.
What about SDF?
That's in the allocation. So
ring fenced?
No. So most of the ring fences were lost this year. I think the mental health investment standard is staying. So I think that will stay, but most of the SDFs were removed this year anyway, and so that will continue into next.
Thank you. Well, you want to come? No. Anything else on Chief Executive's report? If not, thank you. Quality report, Giles.
Thank you, Chair. I will take the report as read, but key highlights. As has previously been mentioned, the Quality Summit has been reconvened for Mid and South Essex NHS Foundation Trust. It was originally set for the 19th of September, but now will take place on the 12th of December, which aligns with the leadership changes which have occurred in the Trust and allowed executive within the Trust time to review and consider the concerns which have been raised. Colleagues will be aware that the Trust Well-Led report has been published, and the report findings will form part of the Quality Summit process in December. We will report obviously the outcomes and the plans back through to the Essex Joint Committee as part of governance process. The second section of the report focuses on National Quality Board and National Quality Strategy updates, of which colleagues at the board will have heard some detail in presentation earlier on today. The important thing is to note the alignment of the plans of the National Quality Board alongside Dr. Penny Dash's review of patient safety across the health and care landscape, with a series of connected interventions planned this year. Positively to note, the expert reference group convened to set the development of the quality strategy has included representation from Mid and South Essex Integrated Care Board, and the team will contribute fully to the process. In addition, in line with the ICB model blueprint and regional model blueprint, the NQB is also now consulting on clarity around responsibilities and accountabilities at provider, ICB, regional and national levels, with the clarity of focus for 26-27. And again, that will be formulated and reported back through to the Essex ICB Joint Committee. To inform the board, as I've previously mentioned, a number of good practice documents following the publication of the Model ICB Blueprint had previously been shared. An additional one in relation to infection prevention and control had been published separately. And we have been working with the infection prevention control team to ensure that the direction of travel within the good practice document is followed. It is important to note that these good practice documents do not change the fundamental direction of travel, which is described in the Model ICB Blueprint. And that concludes the quality report, Chair, and I'm happy to take any questions.
Thanks. I mean, would it be fair to say that in the new disposition of responsibilities for quality between ICB, providers and regional NHS, that's something that we're going to have to be working together to find out what it really means, or is it just my lack of reading skills?
No, not at all. I think similarly to other guidance, it is an iterative process. I think we are working on this together. We don't yet have the final clarity around expectation, around accountability and responsibility, but positively the national team are engaging with stakeholders across the system so that when this does land, it is clear for all and we're able to move forward and pull in the same direction.
Yeah, I mean, we must work together no matter what. And it's not a quality system if it sets one bunch up against another, is it? Indeed. All the research tells you that's hopeless. So we understand that, but it is a new way of working, and well, I guess we'll have to feel our way into it. So, we'll wait and see. And is it you who's involved in the national framework?
Yes, it is.
All right, well done. Lucy.
Mike, you sort of preempted my
I'm
question
sorry.
actually in part. I mean, I think it's very difficult for providers still at the moment to understand what their new responsibilities are going to be. Indeed, I'm actually holding vacancies and trying not to restructure until those things are clear to ensure that we do take on any additional responsibility appropriately. The other thing I would just reflect on is the alignment or misalignment with any potential proposed changes with the still very old-fashioned CQC regulatory and inspection approaches. So it's hoping that through your national links, you can make sure that some of that work is triangulated so that we're not getting mixed messages about what our responsibilities indeed are going forward.
Yes, so the work led nationally is by Aidan Fowler, who's now back in the national team, who has previously obviously was seconded into CQC. So I think we've got some really good links in that space. So there are positive conversations which are being had to make sure that this aligns. I think underpinning all of this, which came very clearly from the expert reference group, was we must reduce duplication. We must ensure that this is a seamless process, that it is open and transparent, and ultimately that the residents that we serve are central to anything that we do.
That's good, but to get their undivided attention, tell them they're old-fashioned.
Career limiting, not quite yet.
Joe.
Thanks, Chair. Giles, I was listening to Radio 4 the other day, and there was an interesting piece came across on the overprescription of antibiotics and its long-term threat to society globally. I mean, there's some statistics bandied around which were fairly frightening. So I just wondered in the context, and maybe Anna might want to comment on this as well, in terms of primary care within the system and going forward, are there any initiatives underway which might save us some money on over-medication, et cetera, et cetera, et cetera?
I will look to my right. My esteemed colleague, Dr. Matt Sweeting, will answer that question.
Thank you, Giles.
Thanks, Joe. In fact, literally as you were speaking, a letter from the National Medical Director has landed around the priority of antimicrobial stewardship and resistance, and calling all providers and ICBs to arms in this space. In terms of our system performance at the moment, we know that we are good at not prescribing broad spectrum antibiotics, but we have a problem with the overuse of antibiotics in children, particularly as well. It is an issue. It's an issue nationally and globally. And we are looking more and more at action plans and how to deal with it. The good thing is we've actually secured funding within the ICB over a 2-year period to have a task force and action log to start to look at this and implement. It's going to be embedded into providers, but actually there is a national drive coming from, including having champions at board level to put this on the agenda. So it's right up there. We're being asked to champion it at a board level. We do have pockets of good practice here and also pockets where we need to improve. And we've just secured 2 years worth of some national funding to look at antimicrobial stewardship across our system going forward as well.
Thank you very much.
Thanks. Neha, and then Anna, if there's anything you'd like to add.
I think just to add to that, and Matt, it did come to quality some time ago now, which was around community pharmacists and pharmacy leading that awareness and that stewardship as well, which is quite effective, and not especially in, well, perhaps not so much in the UK only, but globally, because it's a global issue, AMR, in terms of that community stewardship is extremely important, not just at, kind of primary care or secondary care levels. So yeah, we do have that. I don't know the details. It did come to quality. Am I right, Chelsea?
Yes.
So I suppose I'd just add that currently GPs are monitored on their antibiotic prescribing via the MOLS prescribing framework, which means that we get incentivized for hitting targets, ensuring that we restrict antibiotic prescribing to appropriate levels. And it would be good to see those sorts of schemes rolled out right across the system.
Thank you. Paul?
So it's just to go back to the question about quality and the accountability for quality. And it's great that, well, it's a question, Giles, I reckon, about how open do you think people are to be influenced about how quality should be overseen? And if they are open, what is this? I presume you'll be speaking to them on behalf of this board. What are we saying?
So yes, I think the centre is open. I think the National Quality Board, from the conversations that I've had with members of the NQB, really do want to hear. They are, rather than just necessarily going through formal channels, which of course is appropriate, there are more informal conversations which are being had. I think, as I said, I think the message that they have received loudly and clearly from the whole of the system, and also from patients and their representatives, is make this process simple, remove the bureaucracy, speak in a language that we all understand, and be really, really clear about what you expect from us. And I think that's really, really going to drive the new strategy as it's published. So people can fall back very easily into their old ways of speaking and producing documents. What's been really positive is that's been picked up across the system to say, we have to do something different. We have to have a call to action. And it really is about us collectively achieving what we all say we want to achieve, which is the best possible care as consistently as possible for our populations. And that's great. So they are truly open, and they're rewriting actually as we speak what they've initially put out as a draft. So that's positive.
I think that's great, actually, and I think it'd be really important to pick up Mike's point as well about making sure that it's a quality system and not people doing their bits of quality in the system. Yeah, thank you.
Sarah, is there any public health angle going back to the antibiotics? Because I remember just a few years ago, one of the biggest areas of overprescription of antibiotics was in preparing meat for human consumption. Chickens being given amoxicillin was one of the sort of big issues of the day. Has that now come and gone?
It's not something that's come across my desk in recent years, but I think the focus has mainly shifted on the GP prescribing and the monitoring through that route. It's not a topical conversation from public health routes at the minute.
Which therefore means it probably isn't an issue.
No.
Thank you. So Lucy and then George.
Just very quickly, I do think there's work we can still do around public expectations and parental expectations, particularly for children's prescribing. They definitely do feel children are very difficult to support when they're unwell, and they do feel sometimes that they haven't got what they need or want if they're not prescribed, particularly antibiotics. So I still think there's education in that space, and certainly through perhaps some of our children's services, we can continue to do that.
Yeah, thank you. Well, just on that one, and then I'll go to George. Anna?
So just to respond to that, one of the unintended consequences of the drive to increase same-day access means that there is fewer in-person consultations that we will see for children. So more remote consulting and telephone consulting, which is going to increase the amount of antibiotic prescribing, I'm afraid.
All right. This is because of an abundance of caution.
Yes, that is it. And also it takes twice as long to explain why you're not going to prescribe an antibiotic as it does to write a prescription for one.
Yeah. Yes, I mean, there's lots on the NHS website about when you don't need antibiotics, isn't there? It's quite good actually, but the question is who goes there? And probably if people are trying to get an appointment, they've already been there.
Discussion, but pressure on parents, working parents for nursery, and because they won't take it. And actually, even after you prescribe antibiotics, you have to keep the child at home for 24 hours.
I see, yeah.
So a lot of the parents just straight away go and want antibiotics so they can get kids back.
The pressure's gone up the chain, yes. George.
Thanks, Mike. I was just going to add that there was an article picking up Joe's piece of Radio 4 that about 8 million adults are on antidepressants. That's gone up every year.
Yep.
So you wonder what our prescribing bill is if you start looking.
I mean, it's a wider sociological discussion, isn't it? I think than this board, but I agree with you, and particularly as we've already talked about lower level mental health intervention as opposed to moderate to severe depression as well, and the interventions required. I think those discussions are ongoing and in the round, but you are seeing wider societal change. It's probably for a discussion outside of here, but yeah.
Thanks. Dawn, is there the CQC is on obviously Giles' quality report. So is there anything you'd like to say to us about what is going on within the hospital? Because you'll be completely aware of what is happening. Just sort of a bit of an update.
Yeah, thanks, Mike. So we've definitely obviously taken on board the feedback, and colleagues might have seen the note to the public to recognise the fact that we absolutely need to do better for our patients. We've got an action plan that we are progressing in line with the Quality Summit that's due on the 12th of December. And we're currently going through a restructuring the organisation to reflect the governance requirements. So work is underway in response to that.
Thank you. Yeah, so presumably when we get to the quality seminar, you'll be saying sort of what is actually happening on the ground to give people a flavour of that. Okay, thank you. So are we done on the quality report? So thank you, Giles. Finance performance report, and Jen is away, so we've got Ashley. You're most welcome.
Thank you. And I've been asked to put out a few points on the finance and part of the paper, but I'll obviously take it as read. So the report itself presents a month 6 position following detailed review at Finance Performance Committee on the 4th of November. As a month 6, the ICB is reporting a year-to-date delivery and forecast in line with plan. Key movements since the previous month 4 report presented to the board include an improvement in the acute position as activities move back in line with the indicative activity plans. However, the ICB is continuing to see pressures in health-funded package of care, particularly within all-age continuing care and discharge to assess. In regards to the system position at month 6, the system was reporting a year-to-date deficit position, although continues to forecast in line with plan. Discussions have been had at Finance Performance Committee on the likelihood of delivery against this, given the current run rate position, and it is acknowledged it is incredibly challenging. System providers are currently working through their best, worst and likely positions, but until organisations change their reported position, the plan position will continue to be presented in the ICB papers. I think Joe might have a comment on this afterwards. Before I open up though for questions, Jen did want me to raise or note the efforts of the team, given the embedding of the new financial system which has been rolled out across the country, which has been incredibly challenging. Audit Committee have been appraised with a further update due to go to Audit Committee next week on this. So I'll take the papers read to the Chair and open for questions.
Thank you. I mean, yet more change and shifts while we're dealing with all of the above matters. So thanks to the whole finance team. It can be quite dramatic. The paper, I think, probably understates there, because if we don't honour our financial promises, then yet more money is taken away from us now by NHS England. So it's absolutely crucial that we honour those promises. We're in danger of not. I know that there was work going on to see if, so to speak, as a team, money could be found somewhere to, prop up where a particular hospital was struggling in a particular month. I don't know, have we been able to do that, or is yet undecided, or where are we with that? Because this catastrophic is a bad word to use, isn't it? And keeping therefore medically calm, it could be potentially catastrophic. So we need to make sure that we don't go into that territory. Where are we?
Yes, so that links into the work that Ashley set out about each organisation doing their best, likely, and worst case scenarios. And I think once we're clear on what those are, we can then consider in terms of what options might there be in terms of mutual support or any other activities we can do to support any individual organisation to help deliver system balance. Okay, so you're both speaking in code, saying that we're going to do what we can to avoid that. Well, we need to understand what is the scale of the challenge, and is that challenge bridgeable or not? Yeah, and that's the work that needs to be done. And of course, if it opens up so bad, there are limits, because there is a limited amount ultimately within the system. Yes, Joe.
Thanks, Chair. I just welcome the opportunity to say a few words to the board, because this was a subject of quite a strong conversation and debate at F&P. And I think a number of us were of the view that based on run rate and based on improving value progress and efficiencies and the like not delivered, it becomes very difficult to see how one could forecast we will break even and balance. And that feels then disingenuous to report both to board and elsewhere. So that was our fundamental concern. Notwithstanding that, I appreciate all the efforts that are ongoing, but we do regularly and have regularly heard there's nothing left in the cupboard to raid to make good any shortfall. So if it's all down to run rate now, we don't really see how the projection for month 12, this miraculous recovery, will come about. And I just wanted to put that on the record, make sure the board's well aware of that. So we're being transparent and open, because I think, to your comment, Chair, the report somewhat understates that. And when you're in the position, which I don't envy MSCFT particularly being in, which is you're already in trouble and the rug gets pulled by withdrawing funding, they just compound the problem. I'm not a fan of that. I've spoken out about it in the past, and I wish you luck with it, Dawn. But we need to be straight with our board where we are. Thank you, Chair.
Yeah, I will invite Dawn to say something. I mean, this is potentially the withdrawal of tens of millions of pounds that we're talking about, isn't it, Dawn?
Yeah, that's correct. So in terms of the deficit support funding that the Trust has access to for this year, it's planned for £85 million in line with the planned deficit. And currently it's £34 million that we will have taken away from the system if the full plan isn't met. I think it's fair to say that the challenge really is around the reduction in workforce, particularly closing beds, which was one of our key improving value schemes, and also the reduction in some of the outpatient services. So that's another area in conflict with the response to trying to meet the waiting times target. So that's some of the challenge. We've seen good progress in other areas of our improving value programme, but obviously the full target of £117 million for the year is obviously a significant challenge. So,
thank you. And we've had recent industrial action, and that's been reported around this table as having, albeit a much smaller pressure economically than any of our sort of day-to-day issues here reported. What has that been like this time in terms of financial pressure?
So in terms of confirmation, we haven't got the detail yet because it's only completed earlier this week. But the teams responded well, and we maintained a significant proportion of our elective activity. So we hope not to have lost elective activity during that time, prioritising obviously cancer patient care. But inevitably, we did have a number of doctor strikes, so we have only focused on those priority services during that time. But the team did a fantastic job to maintain services during that period of time.
Right, and do you have a feeling as to whether the financial consequence of that is likely to be more than last time or less? Not yet.
No, I don't have a feel, but based on the performance, I would anticipate it will be of a similar magnitude to last time.
Okay, thank you. So shall we then move on to performance report?
I'm gonna cover this, Mike. In terms of, don't worry. I think in terms of drawing attention to the key areas of concern, so I think the key areas of concern are firstly, referral to treatment waiting times and particularly the number of long waiters. We have clearly have a significant challenge in Mid and South Essex. We are working with MSEFT and we're working with NHS England, particularly in terms of to agree the revised trajectory around the long waiting position and what can be done in order to resolve that. In terms of some of the practical actions that we have obviously taken so far this year is we've commissioned significant additional capacity from the independent sector and we are working to look at what other opportunities that we've got in terms of to support some of the most challenged elective pathways, so particularly ENT services, the ongoing procurement we've got around trauma and orthopaedic services, and indeed we also have now successfully completed the procurement around dermatology services as well. Alongside that is cancer performance, which again, this is the cancer access standards and the fast diagnostic standard. Again, there are a set of interventions in place between the ICB, MSEFT and NHS England in terms of the steps required in order to get that performance back on track, because for both of those two areas we are towards the bottom of the league table. So there's a lot of work that we need to do in both of those two areas. And then in terms of urgent and emergency care performance, so we have seen improvement over the course of the summer, but I think it is fair to say we are now seeing winter emerge and the pressures associated with winter. And so I know we are seeing kind of probably unacceptable levels of crowding within the emergency departments within our hospital or hospitals. And so the focused work around the continuing to strengthen the the Strategic Coordination Centre and the Unscheduled Care Coordination Hub is important. We do know that where we do take concentrated action, we can see improvement, which is reflected within the Alliance report. When we come onto that, if you look at actually the number of admissions from care homes following the specific action we took in that area, we can make a real difference. And so one of the pieces of work me and Dawn have been talking about recently is trying to understand, is there specific cohorts of the population which are driving some of this demand and driving some of this challenge, and what can we do working across the system in order to address it, building on some of the good things that we've managed to do so far. But we are anticipating it's going to be a challenging winter. We have obviously seen the winter plan through other mechanisms, but we're going to need to maintain a laser-like focus on this as we go through December and into February at the very earliest.
Tom or Dawn, there's been a lot of discussion about corridor care. Do we anticipate that will be a big issue for us this year? And is there still an ongoing requirement for monitoring of it separately?
So there are protocols in place, aren't there, in terms of corridor care and temporary escalation spaces. But I don't know, Dawn, if you want to talk a bit about the approach of the Trust.
Thank you. So regrettably, we do have corridor care, and we report that on a monthly basis in terms of the numbers of patients that we sadly care for in the corridors. And we do have a protocol where patients receive information should they have care in the corridor. We've recently had a review by NHS England across all of our 3 sites, and they complemented our approach on the communication with patients and the care that we're giving. As part of our CQC response to our improvement plan, eliminating corridor care is a focus that we're putting on over the coming months, which obviously will be a significant challenge when we've got high volumes of patients currently in that situation. It's not just patients in corridor. We also have a number of patients each morning that are awaiting a bed in our emergency departments. So it's really important that we make sure that system flow is really in place. But can I just acknowledge the integrated care hub work, because that is having a massive difference in the impact, and that is impacting. We've got a reduction in the trend for admissions, so we've flatlined in terms of the number of admissions that come into the hospital, but it is the number of attendances that are increasing, which is a significant challenge.
Thanks. Thank you. Other questions or comments on the performance aspects of the report? You're happy with the discussion? Thank you. Oh, sorry, Matt. So sorry.
Sorry, it was just to mention, we mentioned it briefly, flu is obviously a concern this year as well. So we're seeing influenza A appearing earlier in the season with increasing numbers, and we're seeing that affected in hospital admissions as well. I'm using every public forum at the moment to promote vaccination, which is our most effective method. We know that the vaccine this year is effective. We are doing pretty well in our over 65 cohort. Where we're not doing so well is our children and under 65s with long-term conditions. And obviously with providers around the room here, our own staff, and preventing transmission that way, because obviously it keeps a healthy workforce. So Lucy, you'll be proud of me. I'm doing my public health bit here as well. But just to really say, we are concerned about it. We do have an effective vaccine. And a big shout out to the vaccine bus that's been rolling out around Chelmsford and others to vaccinate people across Essex.
I've been a good boy. Anna?
I'm just wondering if we've got any idea why the vaccination rates are lower this year.
The initial vaccine rates, there's increased uptake amongst some of our core groups to start off with. So we're seeing a better than performance from last year. The wider conversation around vaccine hesitancy is a societal one. Interestingly, the countries with more autocratic regimes seem to have better vaccination rates. We won't be going there. But there are lots of discussions around misinformation, and also side effect profile of vaccines. And again, we know the side effect profile of vaccines, very low side effect profile, and serious complications, less than 1 in a million.
So we are vaccinating more patients than we did last year?
Yeah.
Okay, so we're doing better than we were?
We are, but vaccine hesitancy is a thing.
Yeah, but from a very low base. So relatively, we were very poor last year in Mid and South Essex. So although we're doing better, we've still got a long way to go to, get up to kind of good levels of vaccine coverage. So I think we've made some good progress, but opportunity for us to do more.
I think I've got Neha, Sarah, Jeffrey, and then Giles, and Claire.
Yeah, thank you, Mike. Matt, I attended an Academy of Medical Sciences forum, which was looking at vaccine hesitancy and looked at various different parameters across countries. And one of the things they noted in many places was that actually post-COVID, hesitancy has increased, of course, due to misinformation and some of the, kind of the misinformed campaigns and so on. This year, however, one of the speakers opined that because there has been some scientific awareness around, discussions and so on in the public forums as well, which was actually stating that it is more important to get a flu vaccine this time, even though we know that the vaccines are going to be less effective because the new strain mutated in June when the vaccines were made in February. And that has been unfortunately being used for misinformation, saying that was the point. And I think I've heard this in various other scientific forums that they're trying to now, manage the communication in a way that it is not misinterpreted. And just to end on a positive note, we managed to do enough awareness that I'm a trustee of a local theatre and the Panto cast gets vaccinated because last year we had to cancel 2 performances because of the absences.
Oh no, you didn't. Sarah.
Yeah, so I had a communication from UKHSA last week to say that testing has proved that the current vaccine is very effective against the new strain. So that's good news. The other thing just to say is that we're working with James Halden and the regional team to look at piloting some different approaches to tackling vaccine hesitancy using some of the voluntary sector to be able to look at getting into communities in a different way. I think learning from COVID is definitely that we need to target carefully, because hesitancy has different reasons for different population groups. So we're going to do one pilot in November and then do something else with a different vaccine in January. So not necessarily flu, but vaccine hesitancy in general. So there is some things that we are trying to change. It's just a really challenging thing to tackle.
So I was working my way through the queue, if that's okay. So I think it was Jeffrey next, and then Claire. Oh, no, then Giles, and then Anna, or if I got it wrong.
Shall I?
Definitely you next.
Thank you. Yeah, I think Sarah's kind of picked on the point I was going to say, which is around the COVID issue and the vaccination and the hesitancy. I think there's a lot of complex issues there. I mean, in another life, I'm involved in kind of how you deal with that and how you work with different community groups to do that. And it's a very long-term process. But this year, the emphasis is on working with people with long-term conditions, like you said, Matt, and also schools as well. So I was pleased to read something about community pharmacists doing a lot, but because I think there's much more they can do, and that's good. But my question is, to what extent are we targeting and resourcing some of this targeted work with community groups and so forth, but around long-term conditions and schools as well? Are we doing anything in that space? Rather than, just to make my point, driving around Essex.
Yeah, you're right. I've mentioned one of the interventions from the bus, but Claire, I don't know if you want to come in here actually, because you've been very close to the campaign, haven't you?
Thanks, Matt. And partly what I was going to say when it was my turn was it's actually the big flu weekend this weekend, the NHS big flu weekend this weekend. So there's lots of work going on locally with walk-in opportunities for people to have their vaccine. So anything you see that, there's lots of promotion that we're doing around that. So please do share that on your channels as well. In terms of the targeted approach, we followed the pattern that we have done before. And I'm interested to hear what you were saying, Sarah, about that, because we have got some established work already going on in MSE with our research engagement network around those groups helping to support. And part of the funding that we get a very small amount of funding to support comms and engagement and behaviour change in vaccination. But we do use that for micro grants with voluntary and community sector organisations to help them to promote the vaccine to their own communities. So it's not an authoritarian voice coming from us saying have it, but actually peers and trusted partners within their own communities to do that. And we've had some success with that. It's very small and very low level, which it needs to be to gain that trust with those communities. But that work is there, but we just probably need to look at how we can scale that in the appropriate way so that it still has that really local impact.
Maybe you could join the group. It's a very small group, but maybe then we can feed in what you already know and what's happening so we don't duplicate.
Yeah, that would be brilliant. Giles.
Yes, so to follow on in terms of my public health responsibilities, we mustn't forget RSV, because we do know that the data is showing that there is an increase in RSV, which can really, really cause severe problems for young babies and also for older adults. The vaccine is free, so please do remember that if you are pregnant, you can get a free RSV vaccine after 28 weeks. And of course, if you are between 75 and 79, you can also get a free vaccine for RSV, which is available in pharmacies across Essex and Suffolk.
Thank you. Anna, I think next.
So I've been hearing that there's saturation reaching in community pharmacy. So one of the big changes since the flu vaccine campaign last year is that pharmacies are now actively involved in Pharmacy First, which is provision of appointments for a range of minor health conditions. Now, the remuneration for Pharmacy First consultations exceeds that of vaccinations. So I think we do need to look carefully at what the community pharmacy are choosing to use their limited space for. And it may be that in the future, there needs to be more remuneration given to the flu vaccination to make it more likely, or we just have to balance it basically. There's a lack of capacity in the system, and it's not just primary care, it's not just general practice, it's broader primary care, including community pharmacy, that are getting saturated.
that will explain why I wasn't bombarded with emails or
Exactly
whatever.
that. We've seen a
Yeah.
definite change of emphasis on the ground away from flu vaccination.
Last year, I couldn't schedule in with the GP, so we went to the pharmacy, but there were no emails this year. That will explain it, wouldn't it? Okay, thank you. Dawn?
Thank you. So just to say that the trust is currently at 35%, which is higher than where we were this time last year. We've also been trialling something which is vaccinating some of our members of the public. And when we've tested the thinking around why people would pick the vaccine in a hospital is exactly that, it's the access to the pharmacist. And it was people that we vaccinated that wouldn't normally have accessed care as well. So that health inequalities piece was really good. So just to reinforce that message.
I mean, you can see why people might be, I don't know whether hesitant is the right word, but you know, when you see the recent report that actually, you know, people within the NHS, the take-up's 30%, well, you can easily think, well, they're not bothered. So they're not scared, so why should I be scared? Now, you know, so I mean, one of the things to encourage people surely has to be for us to work on those numbers, doesn't it? Because it just says it's not important. Somehow.
So as part of my NHS appraisal, I'm asked if I'm fully vaccinated, including flu vaccination for frontline healthcare professionals.
Yes.
So you know, it's certainly an expectation of general practitioners that we are vaccinated.
Interesting. Okay, well, so is that it on the performance report? We've sort of veered into important territory as we prepare for winter. Thank you very much. Primary Care and Alliance report. And who's talking to that? Emily?
Yeah, I'm going to talk to that for this month. Very exciting that Beverly will be taking this over. But it's been great to have the opportunity to get to know our alliances and our primary care space in more detail over the last couple of months. And I'd like to extend my thanks to all the colleagues in that space for their kind of ongoing support and work during a significant period of transition for them. And as you'll see, if I take the report as read, there is a huge amount of activity and some great progress that's being highlighted in this agenda. And much of it has actually come out through the conversations that we've had already. So Tom has mentioned a couple of the successes we've had in the primary care space, the new kind of Beauty Health Centre. We've got our first kind of learning disability friendly practice. We've just had a conversation about the support that pharmacies are providing around supporting the winter vaccination programme. We've had huge uptake and interest in extending our dental access and meeting targets, potentially exceeding those targets across Mid and South Essex, and a new dental practice as well. And all of that is supporting Mid and South Essex to just be ahead of the national average of access to consultations within 14 days across primary care. So I think that's something to celebrate, although I'm sure we can always do better, and we will keep focusing on that. Also, my huge thanks go to members of not just the primary care team, but across the whole organisation for support around the situation we've had around the holidays and ensuring that patients could continue to access care through a challenging situation. Looking across our alliances, we've had a lot of discussion across particularly the joint committee today on the importance of developing our integrated our future neighbourhood teams, building on the foundations that we already have. And so the report talks about a number of different areas in this space around the work that we've got going on in integrated neighbourhood teams, and some of the green shoots that we're seeing there, and some of the data that's coming out across key performance indicators to reduce emergency admissions, whether that's from falls or people from care homes, supporting people to stay in their preferred location of living and location of care, which is really positive, improving the number of people we have on various registers. And I think it's a great opportunity for Essex to have engagement in both the National Neighbourhood Health Improvement Implementation Programme, I'm going to get the acronyms wrong, sorry, but also on the national part of a National Frailty Programme in Mid and South Essex, which is really fantastic. but also great to see some of the wider opportunities we have in our localities, such as the Pride in Place opportunities that we have across a number of different locations, participation as part of the Coastal Navigator Network community. So it's really great to see that a lot of those are really community-based activities, which are linking in with our integrated neighbourhood teamwork, with what we've got going across with our councils and providers in areas around the Better Care Fund. So yeah, my thanks go to all the teams who are continuing to work in this space. And whilst we have a lot of opportunity to develop and transform the model of care, I think it's really encouraging how much we're continuing to see progress, and that hopefully the foundations that have been set over the last couple of years are going to be a really solid place to move forward from.
Thank you, and I mean, I agree with that sentiment particularly because just the first few paragraphs here on access and you know, the new requirements. I mean, time was we'd have been a laggard in that sort of space, and actually we're not. So that is, you know, that's just wonderful to see that notwithstanding all the above that's going on, we're clinging on to that. That's really good. Anna.
Thank you, Mike. Thank you for those words. That's what I was going to say. I was going to pay tribute to the primary care clinicians and managers right across Mid and South Essex who've done such a good job at moving to the online access. All bar one practice is now delivering this, and we are exceeding the national average for the number of consultations done within 14 days. So, you know, this has been a really, really significant change for my colleagues on the ground, and I think we've done it with almost no fuss, and you know, continuing to show that primary care leads in the delivery of services for the system. Thank you.
Yes, and it's much appreciated. I did find myself saying with practice, but you know, that's a good move. George, yeah.
Mike, is it worthwhile the board sending a letter of recognition to the primary care colleagues?
Would it be appreciated?
It would be.
Okay. All right, we'll do that. Thank you. Other comments or questions on this report? It is encouraging that things are still happening. Yes, Jeffrey.
Thank you. Thank you, Emily, for fronting this report. I think I'm going to ask a question around the neighborhood footprint, really, which is actually links back to an area you've been working in. And I know that over this month and maybe next month, there's a lot of discussion around, what's the geography of all of this. Can I just check? And we've got a 50,000 population as well, and some of this might align with the PCN footprint, isn't it? So what's the conversation there? Are we trying to go through PCN footprint somewhere? And also, that's the first question. The second bit, very quickly, is what do we anticipate the leadership and the governance at that level? And I'm thinking, how inclusive do we make it be? Otherwise, it'll all be primary care or all this, and some thinking around inclusivity. Thank you.
Answers on a postcard, please.
So
That's a challenging question.
I'll start, but I'm sure Tom will have more to add in this space. So I think, Javi, there are very practical conversations happening at the moment around the balance of what constitutes a neighbourhood based on how a population comes together across a geography, across a defined set of characteristics. As you've indicated, 50,000 is the kind of nominal size of what NHS England have indicated as a neighbourhood, but we're also thinking about how those neighbourhoods might come together at something called the multi-neighbourhood size, which is potentially closer to 250,000. I think there's a recognition across the country, not just in Mid and South Essex, in how primary care networks previously evolved, that they weren't always neatly geographically focused, and that will form part of the conversation that we need to have in terms of forming the right neighbourhoods for Essex to get the best outcomes for our population. Those discussions are being had actively at the moment, both through our alliance partnerships and through leadership conversations that Tom and James Holden are leading. So I think that's a very active discussion at the moment. And I think part of those conversations will also form the second part of your question, which is what's the right kind of leadership and governance in that space. Clearly, we don't quite know yet. Sarah referenced in an earlier discussion about the fact that we're in the LGR consultation period for Essex at the moment. And so the other thing we're trying to balance is how do you define neighbourhoods for Essex in that uncertainty, given the importance of upper tier local authority footprints for the future, alignment around neighbourhood health plans, which will need to be often at that level. So I think there's a tightrope to be walked at the moment in terms of how we get those communities to come together without tripping ourselves up in what we don't know about the future yet. But I do think it's positive that there are active discussions happening in Essex at the moment in all of those areas.
Tom and then Anna.
Yeah, so I think we're not going to be slavish to the 50,000. So I think the test for neighbourhoods is where do you say you live? Where would your mum say that they live? That's your neighbourhood you live in, right? So that's the test we're going to apply. Equally, I think alongside that, we will need to work with PCNs where there isn't natural alignment. In many places there is actually, but we know that there's going to be some places that there isn't. And so I was at as with Paul actually, in terms of the PCN conference that the LMC did a few weeks ago. And so started, to explore that conversation. I think then beyond that, I think in terms of the leadership arrangements at neighbourhood level, one of the things that we will need to go ahead around as an ICB is what do we want to commission from neighbourhoods, and partly that will then drive what the leadership requirements are. And there is going to be an opportunity to, I think, in terms of working with local authority partners around how do we join up some of the commissioning we're currently doing at a neighbourhood and a multi-neighbourhood level, so we can kind of start to build sustainable mechanisms for provision of service that can start to take on some of the leadership of the development of the neighbourhood health service, because with the changing role of the ICB, changing resources of the ICB, we're not going to be able to do some of the things that we've historically done in this space. But equally, we can also be very clear in terms of this is our expectations around who's around the table, who has a say in terms of decision making to make sure it is inclusive and representative of local communities.
Anna?
Thank you. So it's a really good opportunity here to form firm foundations for neighbourhood health. In the majority of the patch, PCNs align with neighbourhoods. So that's the first thing to say. This isn't a big problem in Essex. There are a few areas where there needs to be some refinement, but by and large, what you would call a primary care network is a geographically aligned neighbourhood. And the other thing to say is that within a primary care network, there is a clinical director who is paid by NHS England. So these are clinical leadership roles that are paid for from NHS England centrally. The big issue we have is that in a lot of primary care networks, those clinical directors who are usually general practitioners, but not necessarily, they can be any clinician, pharmacist, nurse practitioner, for example, they're spending a lot of their time doing work which isn't strategic in nature. It's human resources type work because of the complexities around employing the Rs staff, and the budget for the Rs staff has been climbing every year, and that's really a very, very significant amount of money that's now sitting in primary care networks. So one of the things we have to do going forward is look at how we mature the neighbourhood health system to utilise the expertise of the clinical directors to the best of their abilities, and ensure that we support the wider sort of functions of the neighbourhood health, maybe by looking at bringing some of those together so that we can operate on slightly bigger footprints, which will be more efficient.
Thanks, Anna. I mean, we should say that the PCNs do resemble that infrastructure in the way you describe, but they didn't always. So again, thanks to you and the primary care team giving leadership, and Matt and people who got into these conversations to get it into that shape, which is tremendous, and thank you. It seems to me that we're going to have to be flexible in the rules we put down, because if we want, I mean, and there's two tracks here, isn't there? There's the neighbourhood hubs, the sort of bigger things, and then there's the neighbourhood teams. And if we want, so there was a discussion at the Essex County Council Health and Wellbeing Board about, well, there's school hubs, family hubs. So, you know, they're there, they happen. What can we use those? So we don't want rules that prohibit that infrastructure from being used, because we've got to look for more efficient ways of doing it. And if they're there, but you can't, it seems to me, to have something with health on it that isn't directed by somebody who knows about that in a serious way. So our leadership has got to allow for that leadership to come in, or it won't be safe, or people won't respect it because they won't know it's safe and all the rest of it. So there's a trick to be pulled off here. And I'm slightly anxious in some of the things I've seen, I think mostly from NHS headquarters. We can't overpromise. You know, if we say all of this will be community led, well, we don't have the money to give the community for it to be led by the community. Yes, the community must have a strong voice in what is going on in there, it seems to me, in some way, but we mustn't overpromise what we can offer people there. And I know there are examples, and you know, my lifelong example, and it's still there now, is the Bromley by Bow Healthy Living setup. That there's 4 GPs who are connected into that. It's set up as a charity, so it is led by the community. But if you're going to put that in place, you'll need to have the money to help that charity get set up in the first place. I think they're now self-sustaining. You can go on their website and see the huge list of organisations that they managed to garner money from. But that doesn't happen overnight. You have to pump prime people in order for that to happen. So I just think we've got to make sure that we offer up a view about how this will be put together that is realistic. And, you know, and we were earlier talking about hospices, which exist under the same sort of framework and are now struggling. And there've been national reports about that. So we've got to come up with a model which goes with the grain, gets community involvement, has the respect of the community because it is medically informed, and then it's also affordable. So I think that's what you were saying, Jeffrey, really politely, isn't it? Okay, anything else on this report? If not, then thank you very much. Very encouraging. General governance, the board assurance framework. Tom, you're going to talk about that.
So yes, this is here, I think, for noting, isn't it? So this is the November version of the board assurance framework. I think the 7 BAF risks which are identified. I think we have probably spoken about a number of these as we've gone through the agenda today. I guess the one area we haven't particularly covered is around the primary care estates capital item, which might be something we want to look at in due course, actually, thinking about the future role of the ICB in respect to estates and primary care facilities and community facilities more generally. But I'm happy to take any questions on that.
I think we should come back to that at some point, but before the end of the year, financial year, so to speak. I did wonder, I mean, we've been discussing, we've been very lucky in that we're holding body and soul together with a workforce that's being threatened by, you know, redundancies and so on. So, you know, the workforce instability, it's only under MSEFT. Have we captured that risk adequately, do you think, for ourselves?
So we obviously have a BAF risk, which is workforce, so the first one. So in terms of the sustainability and affordability, and then for the ICB specifically, we have got the ICB transition risk that intends to bring together all of the risks associated with transition, of which one of those is around staff engagement and morale and the ability for the ICB to deliver during the transitional period.
I'm trying to find the page and you've got it. What number did we put on that in the end?
16.
Yeah, you see. Now, is that, well, I think what I'm asking is that, does that actually, you're saying that reflects the risk, because at the moment, actually, we are holding people together
So it's a 4x4, isn't it, in terms of impact and likelihood?
Yeah,
So
yeah.
it's I can't quite remember the terminology. High likelihood, high, not so,
Yeah.
high. So I think it is a critical risk for us. I think it's something we're very aware of. I think we've got in place mechanisms to try and manage that risk in terms of staff around the communications processes that we've got and the various other engagement activities that we particularly have going on now given the consultation. And equally, as we spoke about the joint committee, all of the other transitional work that's going on around due diligence and as we spoke about under that paper. So I would feel that we've got, it is a high risk, Mike, but I feel that we have got some mechanisms in place in order to try and manage that as well as we can.
Yeah. Okay. I mean, high risk in the context of this paperwork is a score of 20. I know the scores are kind of almost neither here nor there, but it's a means of thinking about it, isn't it? And you're saying, and I think it's probably true, but I was asking myself that question. George and Joe want to comment.
Yeah, I think that the last time we did this, Tom, we actually deferred the packages for HR by 90 days. So the HR team were still in place, working through the issues, but they were given a further 90 days at the back end. And I think there's quite a lot of work that we didn't anticipate that I think Joe got involved in with the REMCOM. Jeffrey and I get involved with the appeals panel. So I wouldn't underestimate the amount of work that this is going to generate for HR. For people who want to leave, we don't want them to leave. People who do.
So we have brought in specific additional external resource to supplement HR, and clearly there's been quite a lot of learning, I think, from the last ICB reorganisation. So policies have been updated significantly, and indeed recently approved through remuneration committee to try and minimise that work where it's appropriate for us to minimise that work, but equally also to think about how do we manage things like the voluntary redundancy process. And so it isn't such an elongated process, although there are some restrictions which we hadn't envisaged from the national scheme that we're just getting our heads around, but we think we've got a mechanism so we can run the process in a slick, tight way.
Well done. We minute that carefully and see what happens. But I mean, obviously, you're setting plans and we hope it does go well. Joe, and then I'm going to try and give us all a few minutes back, having had that hiatus in the middle of the afternoon. Joe.
Thanks, Chair. It's just a minor point, really, and you mentioned the scoring is not the be-all and end-all, and I would accept that. I just wonder if we need to try and align the report to the scoring a little bit more. If you look at our view of finance, we're scoring it 4x4 at 16, and our provider's scoring it at 25, which I would suggest is more realistic. So we probably just want to look at a few critical ones for alignment would be all I would say, Chair. Thank you.
I think that's a very good point. Yeah, and people are nodding. Thank you. Thank you, Joe. Okay. Thank you. I'm going to move us on. We've got some new policies. They've been in various places. Everyone happy with those? Thank you very much. And we've got the approved committee minutes. We're not there to challenge those. Does any committee chair want to raise anything specific out of those? If not, thank you very much. I've got no other business, and we've got the date of the next meeting is there. Thank you all very much. And many of you have been here pretty much all day. Much appreciated for your time and commitment to this. Thanks very much. Safe journey home.
Thank you, Mike.
Happy Christmas.